Welcome to this explainer. Today, we're going to completely demystify the macro structure of the brain. Seriously, by the time we're done here, you're going to be equipped to read the cerebral cortex exactly like a finely detailed map. Let's jump right in. So, here's our roadmap for the journey. We're starting out broad by mapping the four main lobes, then zooming way in on the frontal lobe's anatomy and specific subdivisions. After that, we'll look at three fascinating behavioral syndromes, and finally, how doctors actually test these areas right at the bedside. Section 1. Mapping the four lobes. Because before we navigate all that complex circuitry, we really have to get our grand coordinates straight. The brain is all folded up into gyri and sulci, basically so this massive network can actually fit inside a small vault, right? Two major anatomical landmarks define our basic map. First, the frontal lobe. It's separated from the parietal lobe by the central sulcus, which is brilliant because it splits the brain's motor actions in the front from sensory perception in the back. Then there's the lateral fissure, sometimes called the Sylvian fissure, which drops the temporal lobe right below that frontoparietal cortex. And finally, sitting at the very back, we have the occipital lobe, which is dedicated entirely to vision. Before we dig into specific lobe functions, there's a fundamental rule of neurology you gotta know. About 95% of people have a left-dominant language hemisphere. And interestingly enough, this includes the large majority of left-handed folks too. That 95% rule sets up a massive clinical divide. You set the hemisphere first, and the syndrome follows. The dominant hemisphere handles language and calculation. So lesions there produce things like aphasias, literally robbing a patient of language, or calculation issues like Gerstmann syndrome. On the flip side, the non-dominant hemisphere runs space and body schema. Lesions there cause severe spatial neglect, where a patient might just completely ignore the left side of their world, or even deny their own bodily deficits, which is called anosognosia.
Section 2. The frontal lobe engine. Let's see how this all builds into our largest and honestly, arguably most complex territory, the frontal lobe.
As we explore the frontal lobe, keep one single organizing idea in mind. Read circuits, not spots. The brain isn't just a collection of isolated bumps. It's a set of specialized territories, and their connections dictate behavior. When you see a bizarre behavioral breakdown, it's almost always because an interconnected loop got interrupted, not just because a single isolated spot is missing. Sitting anterior to the central sulcus, the frontal lobe makes up roughly a third of the neocortex. It kicks off with a motor tier responsible for executing physical action. Working back to front, we start with the primary motor cortex, or M1. That holds the origin of the cortical spinal tracts that control your limbs. Next up are the premotor and supplementary motor areas, which plan and sequence movements, like fastening your buttons. Then, the frontal eye fields, generating voluntary gaze to the opposite side of your body. And lastly, in the dominant hemisphere, Broca's area handles the insanely complex motor programming required for speech. Now, here's a fascinating clinical trap to remember. The frontal eye fields generate gaze to the opposite side, right? Well, if you have a destructive stroke in that area, the intact opposite side suddenly takes over. The result? The patient's eyes will deviate toward the side of the damaged hemisphere. In neurology, the golden rule is, a destructive lesion looks at the lesion. Section 3. Prefrontal cortex subdivisions. Let's shift gears and look at how we divide up the higher-level cognitive functions. Sitting right in front of that motor tier is the prefrontal cortex, a massive heteromodal association area. What's absolutely wild about the prefrontal cortex is that it's the last part of the brain to myelinate. Synaptic pruning keeps happening well into your mid-20s, which, if you think about it, perfectly explains why adolescent impulse control and judgment simply take time to develop. The hardware is literally still maturing. The best heuristic hook to lock in the three functional prefrontal zones is this classic mnemonic mapping the famous Brodmann areas to their exact executive roles. Just remember, 946 to deliberate, 11 to desire, and 2432 to drive. Let's break down what that actually means in practice. These three zones parse out our very highest cognitive functions. First, the dorsolateral zone, areas 9 and 46, is where we deliberate. It handles working memory, planning, and set shifting. Second, the orbitofrontal cortex, area 11, regulates impulses, desire, and social judgment. And third, the medial and anterior cingulate, areas 24 and 32, provides our baseline drive, motivation, and conflict monitoring. Three zones, three totally unique jobs. Section 4, three frontal lobe syndromes. Now we get to the crucial part. What happens when these specific prefrontal circuits break down? Here is your clinical field guide to prefrontal damage. Because these areas govern vastly different behaviors, lesions look totally distinct at the bedside. Damage to the dorsolateral zone gives a dysexecutive syndrome. Patients just can't plan or shift tasks, often getting stuck repeating the exact same action. Orbitofrontal damage, that causes profound disinhibition. Patients become impulsive, tactless, and emotionally all over the place. And finally, medial or anterior cingulate damage strips away all drive. You see extreme apathy or, in severe cases, a kinetic mutism, where a patient is fully awake but simply won't move or speak. We actually see the absolute classic orbitofrontal disinhibition syndrome in the famous 1848 medical case of Phineas Gage. Gage was a super responsible railway foreman until an explosive accident blasted a tamping iron completely through his skull, destroying his orbital frontal and ventral medial cortex. Amazingly, his intellect and memory survived intact. But his friends noticed he became intensely impulsive, profane, and capricious. As they famously put it, he was no longer Gage. His social circuitry was just gone. Gage's case is the perfect example of the frontal lobe paradox. See, ventral medial damage severs the link between cognitive reasoning and emotional consequence. This means a patient can reason perfectly in the abstract, totally ace standard IQ tests, but then go out and make absolutely disastrous, impulsive, real-world decisions. It is a massive knowing-doing dissociation. Section 5. Bedside Lobe Function Tests. Let's look at how doctors actually interrogate these specific circuits in a clinical setting today. Because you obviously can't test complex frontal lobe loops with a simple reflex hammer, clinicians use specialized cognitive tasks. They might ask a patient to name as many words starting with the letter F in 1 minute, testing verbal fluency. Or they'll use the Wisconsin card sorting test to see if a patient can adapt to new rules, exposing dorsolateral executive failure. There's also the go, no-go test, requiring patients to withhold a response, which is a brilliant way to test orbitofrontal response inhibition. Another really elegant bedside test is the Loria 3-step motor sequence. The doctor just asks the patient to tap the table with a fist, then the edge of their hand, then their open palm, and repeat it smoothly. This directly tests the premotor area's ability to plan and sequence motor actions. A patient with frontal lobe damage will very often get stuck and just fail to complete the sequence. Interestingly, in severe frontal decline, like we see in advanced dementia or major brain injuries, we also see the reemergence of primitive infant reflexes. Things like the grasp reflex, where stroking the palm causes an involuntary grip, or the snout reflex, where tapping the upper lip makes it purse. We're all born with these developmental reflexes, but they are normally suppressed by a healthy, mature frontal cortex. Once the frontal lobe gets damaged, that suppression vanishes and the reflexes come right back. All of this brings us right to the frontier of modern neuroscience. Once we understand that reading the brain is about interconnected loops rather than isolated spots, we can target therapies to specific pathways. We're already using targeted magnetic stimulation directly on the dorsolateral prefrontal cortex to treat severe depression, for example. So if we can map the exact circuits governing our drive, our impulses, and our mood, it leaves us with a huge question. How will next-generation therapies precisely manipulate these maps to cure the most complex psychiatric disorders of our time? It is a map we are still learning to read.